Adhesion to dental tooth tissue. Adhesive dentistry is a relatively new field that has totally revolutionized the face of dentistry. It is based on the concept of adhesion and totally covers the areas of anterior and posterior cosmetic restorations. 4. Innovations in dentistry have always been related to the development of new materials, techniques and equipments, and thus, were always subject to changing and disappearing with the evolution of newer ones. For the first time, the innovation related to adhesion is concept related, whereas the materials and techniques are revolving and changing around this concept to satisfy it and improve it without changing it. 5. The dream of restorative dentistry has always been to develop a material that would totally bond to tooth structure in such a way that, both the tooth and material, would act and react as being one single unit. 6. The concept of adhesion and its application in dentistry has made this dream become, relatively very close, but it has to be understood that, in spite of all the advancements that were achieved in this field, it still is in an infant stage. Thus, in all adhesive dental systems, one should still expect islands of attachments separated by areas of non-attachment. 7. Historical breakthroughs in adhesive dentistry. One experiments on bonding acrylic resin to enamel and dentin began in the early 50s with Dr. Oscar Hugger in England, who developed a monomer based on glycerophosphoric acid. 8. Historical breakthroughs in adhesive dentistry. 2. In 1955, Dr. Michael Buonocore in USA, made the most important advance in this field by identifying the occurrence of micromechanical adhesion to enamel through acid etching. Buonocore is considered to be the father of adhesive dentistry. This innovation was not fully recognized in our profession until the early 70s. 9. Historical breakthroughs in adhesive dentistry. 3. In 1979, Dr. Fusayama in Japan advocated etching and conditioning of dentin using phosphoric acid, starting a new era in this fascinating field. 10. Terminology. Adhesion is the bonding of dissimilar materials by the attraction of atoms or molecules. Adhesive is the material used to produce adhesion, and is always a liquid. Adherend is the surface to which the adhesive is applied, and is always a solid. The components of an adhesive system are present in the process of restoring teeth. I.e., the tooth tissues, enamel and dentin, represent the adherend, while the adhesive restorative material represents the adhesive. 11. Wetting. It is very difficult to make two solid surfaces to adhere completely, regardless of how smooth their surfaces appear to be. They are likely to be rough when considered on a microscopic level. When they are placed in apposition, only the high spots will be in contact. One method to overcome this is to place a fluid between them which will flow into the irregularities and provide for a wider area of contact between the two solid surfaces. 12. So, wetting is the degree of spreading of one drop of liquid on a solid surface, and is measured by the contact angle. 13. Contact angle is the angle formed by the adhesive with the adherend at their interface. It may be 0 or 180 degrees equals maximum adhesion, less than 90 degrees equals moderate adhesion, more than 90 degrees equals poor adhesion. 14. Mechanisms of adhesion in restorative dentistry. 1. Chemical or true adhesion, where there is bonding at the atomic or molecular level. 2. Mechanical attachment, based on the old mechanical retention concept. The adhesive flows into the pores of the adherend where it hardens and interlocks. 15. Retention of adhesive restorations in cavities have not shifted from the old Black's retention principle, which relies on interlocking of restorative materials in undercuts created inside the cavity. Retention of adhesive restorations relies upon the same mechanical principle, but on a microscopic level, micro-retention, aided by some degree of chemical attachment which is present with the new adhesive systems. So, retention of adhesive restorations in our modern practice is mechanico-chemical in nature. 16. A reliable and durable adhesive junction between the tooth tissues and the adhesive restorative material is mandatory for the successful clinical performance of the restoration, in terms of retention, cosmetics, and proper marginal seal. Furthermore, the longevity of this reliable junction under the destructive rigors which are present inside the oral cavity represents the greatest challenge that faces our adhesive practice. 17. Clinical significance of adhesion. Benefits. 1. Inhibition of marginal leakage, which refers the ingress of saliva, food debris, microorganisms, and stains at the tooth restoration interface with its sequelae of recurrent caries, hypersensitivity, discoloration, looseness of the restoration and possible pulp involvement. 2. Reinforcement of the tooth, since adhesion bonds the restorative material to the remaining tooth structure, making them to behave clinically as one single structural entity in sustaining and distributing the forces of mastication. 18. Solving the problem of retention, especially in anterior teeth, where trying to establish adequate mechanical retentive features through undercutting would involve more destruction and weakening of the tooth, if not impossible at all, or would not be sufficient to retain the restorative material securely in place. 4. Adjusting aesthetic defects without the need to grossly reduce the teeth for crowning, anterior cavities, minor discolorations, diastemas, malformed teeth, facings. 5. Fulfilling the requisite of the modern aesthetic practice in placing successful posterior cosmetic restorations. 19. Requirements of a successful adhesive bond. 1. High bond strength values. Bond strength to enamel should be equal or very close to that to dentin, otherwise stresses might concentrate at the interface with subsequent debonding and failure. Bond strength values of 17 to 20 MPa are required to counteract the shrinkage stresses of composites during polymerization, and even higher values are required to resist mastication forces without failure. Recent adhesive systems have reached bond strength values of 34 to 45 MPa and even more, as claimed by some products. 22. Elimination of voids at the interface. The presence of voids at the interface, even in small and separate areas, would disturb the structural continuity of the tooth restoration system, inviting leakage, stress concentration, cracks formation, and their propagation with eventual debonding and failure. Voids are, unavoidably, present in all adhesive resin systems, due to the polymerization shrinkage of the material, its incomplete polymerization, as well as because of the inconsistent demineralization of the tooth tissues. 21. 3. Stability and longevity. The adhesive joint should be free from any dimensional changes due to hardening or thermal changes, should remain hydrolytically stable, and should resist biodegradation in the oral cavity. The long-term stability and longevity of an efficient adhesive junction in the oral cavity is still very much questionable and full of speculations because of the complex interacting damaging rigors which are present in the mouth, stresses, temperature and pH fluctuations, saliva, microorganisms, as well as the heterogeneity of the tooth tissues. 22. Properties that should be present in the tooth tissues, adherend, and in the adhesive in order to provide for a successful adhesive system. 1. The tooth tissues should have a high surface energy to be able to attract the atoms of the adhesive. 2. The tooth tissues should be clean and dry to provide for direct apposition of the adhesive against these tissues. 3. The adhesive should have a low surface tension and low viscosity to be able to properly wet the tooth tissues. 4. The adhesive should be biocompatible with the dentin pulp organ. 23. 5. The adhesive should contain both hydrophilic components to displace water and properly penetrate the tooth surface, and hydrophobic components to copolymerize with the composite resin material. 6. The adhesive should provide for some degree of chemical bond with the tooth tissues, although the longevity of this bond in the oral cavity is still not reliable. 24. Bonding to tooth tissues. Bonding to enamel and dentin is basically mechanical in nature, and depends on the interlocking of an intermediate adhesive layer, bonding agent, inside the micropores created inside enamel and dentin through etching and conditioning. An impregnated hybrid layer is thus formed from resin and tooth tissues and copolymerizes with the composite material. 25. Bonding to tooth tissues. Recent adhesive systems provide for some degree of chemical attachment to tooth substrate through chelation of Ca ions of the tooth tissues, bonding to Ca in the hydroxyapatite crystals, or through bonding to the collagen of dentin trough cross-linking. 26. Hybrid layer resin tags dentin hybrid layer resin tags enamel hybrid layer. 27. Bonding to dentin is more difficult, complicated and less reliable than bonding to enamel due to the following facts. 1. Dentin contains a much lower percentage of inorganic components, 65% as compared to 95% in enamel, which provides for less micropores formation with surface conditioning and decalcification. 2. The surface energy of conditioned dentin surface is much lower than that of enamel, and hence its capability to attract molecules of the adhesive is weaker. 3. The presence of the smear layer on the surface of cut dentin significantly reduces adhesion, unless it is dealt with and removed. 28. 4. The structure of dentin is heterogeneous, less homogeneous than that of enamel, because it contains a much more significant amount of water, which requires a bonding agent that can compete with water and remove it to properly wet the surface. 5. This is further complicated by the intertubular dentinal fluid that runs inside the dentinal tubules under a constant positive pressure of 25 to 30 mm Hg. 6. The dentinal tubules are not regular nor consistent in their number nor sizes, as they vary with alterations in location and depth within the same tooth as well as from one tooth to the other. 28. 29. Enamel dentin. 30. Development of dentin bonding agents. 1. First-generation bonding agents, a comonomer was used, primer, to react chemically with the inorganic Ca-hydroxyapatite N/or with the collagen of dentin, e.g. NPGGMA, N-phenylglycinoglycidyl methacrylate. This system was not successful as it provided for low bond strength values, 2 to 3 MPa. 2. Second-generation bonding systems, phosphate bonding agents. Phosphate esters were added to the bis-GMA resins in an attempt to bond chemically with the phosphate and calcium of dentin. This system was hydrolytically unstable and provided for low bond strength values, 2 to 7 MPa. 31. Third-generation bonding agents. These are the first systems that advocated conditioning of dentin with acids to modify or remove the smear layer. This generation represents one of the major breakthroughs in adhesives and bonding. After the primer was added, an unfilled resin was placed on both dentin and enamel. The weak link with this generation was the unfilled resins that simply did not penetrate the smear layer effectively. 4. Fourth-generation bonding agents. This generation of bonding agents introduced the wet bonding technique, bonding to moist dentin. It is considered to be the basis for all the recent dentin bonding systems as it provided for much higher bond strength values, up to 27 MPa, and exhibited a fairly good durability. 32. 5. Fifth-generation's dentin bonding agents introduced to minimize the clinical steps of bonding by amalgamating more than one step together, example etching followed by one single agent containing both the primer and the adhesive. 6. Sixth-generation dentin bonding agents sought to eliminate the etching step, or to include it chemically in one of the other steps, self-etching primer and adhesive, acidic primer applied to tooth first, followed by adhesive or, self-etching adhesive, 2 bottles or unit dose containing acidic primer and adhesive. 33. 7. The seventh generation or all-in-one bottle, it's a self-etching system represents the latest simplification of adhesive systems. With these systems, all the ingredients required for bonding are placed in and delivered from a single bottle. 8. Eighth generation dentin bonding agents, self-etch which contains nanosized fillers by the addition of nanofillers with an average particle size of 12 nanometers that increases the penetration of resin monomers and the hybrid layer thickness, which in turn improves the mechanical properties of the bonding systems. Nanobonding agents are solutions of nanofillers, which produce better enamel and dentin bond strength, stress absorption, and longer shelf life. 34. Classification of dental adhesives. According to clinical application steps, contemporary adhesives exhibit an common adhesion mechanism of hybridization, a process of micromechanical interlocking occurring by the infiltration of resin into demineralized substrate, creating a resin-infiltrated hybrid layer. This classification was described, in 2001, by Van Meerbeek and was based on the clinical steps of application. 34. 35. 36. Types of adhesives. 1. Etch and rinse adhesives, smear layer removing, A. 3 steps, etching, priming and bonding are done in 3 separate steps. B. 2 steps, etching is in 1 step and primer and bonding in 1 step, incorporated in 1 bottle. Etch and rinse adhesives represent the golden standards for adhesives with proven long-term success. 2 self-etch adhesives, smear layer dissolving, no separate etching step. A. 2 steps, acidic primer in 1 bottle and an adhesive in another bottle. B. All-in-one, acid, primer and adhesive in 1 single bottle. 36, 37, 37, 38, 38, 39, 39, 40, 40, 41. The nano-leakage phenomenon, which is basically the presence of submicrometer-sized gaps within the hybrid layer. It is considered as a manifestation of incomplete resin infiltration of the hybrid layer and of a discrepancy between the depth of demineralization and the depth of resin infiltration. Or due to poor adaptation and envelopment of the resin to the collagen fibrils, leaving microscopic gaps. 41. 42. Self-etch adhesives are further classified according to their acidity or aggressiveness into mild, pH more than 2, intermediate, pH equals 1.5, and strong, pH less than 1. Self-etch adhesives simplify the clinical steps, reduce post-operative sensitivity, do not increase dentin permeability, but exhibit lower bond strength values. 3 glass ionomer adhesives, smear layer modifying, based on the glass ionomer self-adhesive capacity technology. Conditioning of dentin with weak acids, 10 to 20% polyacrylic acid, removes the smear layer and leaves the smear plugs. These adhesives are simple to apply but exhibit low bond strength values. 42, 43, 43, 44, 44, 45. In particular, the high concentrations of water have raised questions about potentially harmful effects on polymerization, given that incomplete water removal can cause water trees. This also applies for the high concentrations of solvent that may cause incomplete resin polymerization in case of incomplete evaporation. 46. Resin modifies glass ionomer adhesive. 46. 47, 47, 48, 48, 49. Universal adhesive systems / multi-mode or multi-purpose adhesives. They may be used as self-etch, SE, adhesives, etch and rinse, ER, adhesives, or as SE adhesives on dentin and ER adhesives on enamel, a technique commonly referred to as selective enamel etching. 50. The composition of universal adhesive differs from the current SE systems by the incorporation of monomers that are capable of producing chemical and micromechanical bond adhesion to the dental substrates. It contains specific carboxylate and / or phosphate monomers that bond ionically to calcium found in hydroxyapatite. For example, Methacryloyloxydecyl Dihydrogen phosphate, MDP, is a functional monomer found in certain new adhesives that helps promote strong adhesion to the tooth surface via formation of non-soluble Ca2 salts. 51. Steps of bonding: A. Selective acid demineralization, etching, conditioning, aiming at decalcifying and removing part of the inorganic content in order to create microscopic undercuts where the adhesive material can flow, and at cleaning the enamel and dentin walls from any contaminants that might, adversely, affect bonding. In enamel, it selectively decalcifies the enamel rods, creating interprismatic pores. Properly etched enamel looks chalky white in appearance. In dentin, it removes the smear layer, creates intertubular and peritubular pores and exposes the dentin collagen, to chemically aid in bonding. Both enamel and dentin are etched with the same etchant in one single step hole etch technique. 52. Resin tags open DT. 53. Conditioned dentin open DT. Intertubular D-collagen network. 54. SEM micrograph of a resin dentin interface. A. Adhesive, D. Residual dentin, H. Hybrid layer, T. Resin tag. 55. Types of acids most commonly used are phosphoric acid, 10 to 37%, and maleic acid, 10%. The acid is supplied in the liquid or gel forms with different colors. It is applied with a small brush, a small piece of sponge, or with the disposable tip of an injectable syringe for a length of time of approximate 15 to 30 seconds. The etchant must be thoroughly washed away with water to remove all the etched products, then enamel and dentin are dried with oil-free compressed air. B. Priming, aiming at increasing the wettability of enamel and dentin. Primers are adhesion-promoting monomers, HEMA, containing both hydrophilic and hydrophobic molecules. The hydrophilic part increases the wettability and permeability of the demineralized enamel and dentin, while the hydrophobic part 56 penetrates inside the created pores where it polymerizes, forming retention tags inside them from the tooth tissue side, and copolymerizes with the subsequently applied bonding agent from the outer side. Acid-etched enamel has high surface energy, whereas etching of dentin decreases its surface energy because of the high protein content after etching. Exposed collagen, in addition to the fact that its permeability and wetness increase, which hinder adhesion furthermore. So, the primer is essential to ensure sufficient wetting of dentin, displace residual water and carry the monomer inside the created microporosities. The primer, usually, contains organic solvents, acetone or ethanol, which act as water chasers, displacing water from dentinal surfaces, thus promoting the infiltration of monomers through the exposed collagen. 57. The primer is applied with small brushes or sponges, is subjected to a light stream of air to spread it, not the extent of removing it or to cause collapse of the collagen bundles, and is then left undisturbed for at least 15 seconds. Enamel and dentin must appear glossy after air spraying of the primer. C. Bonding agent, adhesive resin, is a solvent-free low viscosity filled or unfilled solution containing mainly hydrophobic monomers. It copolymerizes with the primer that has penetrated the undercuts from one side and with the subsequently applied composite resin from the other side. It is applied with a brush or small sponge, gently air-thinned and light-cured. This is the final step in bonding, and is followed by the application of the composite resin. 58E. And D. Etching chalky white appearance of enamel priming glossy surface. 59. Bonding agent application light curing after curing. 60. Smear layer, following cutting of dentin with rotary tools, a layer 2 to 5 microns in thickness is formed on the surface of dentin. This layer is loosely attached to dentin, but is burnished on the cut dentin surface by the effect of heat and pressure during cutting and cannot be removed by rinsing. It is formed of cut dentin chips, hydroxyapatite crystals, collagen, saliva and blood, and it incorporates microorganisms. Advantages of this layer is that it plugs the dentinal tubules and reduces the flow of dentinal fluids, reduces dentin permeability, thus providing for a drier surface for bonding and minimizing post-operative hypersensitivity. Disadvantages of this layer is that it is loosely attached to the underlying dentin, providing for weak bonding, and it incorporates microorganisms. 61. Adhesive systems should totally remove the smear layer or penetrate through it to provide for efficient bonding. Etch and rinse adhesives totally remove the smear layer. Self-etch adhesives dissolve the smear layer and incorporate it into the hybrid layer. Glass ionomer adhesives remove the smear layer and leaves the smear plugs. 62. Wet bonding versus dry bonding. Following etching and rinsing, enamel and dentin present different conditions for priming and bonding. Whereas enamel should be dry to provide for good bonding, dentin should be a little wet to prevent collapse of its collagen bundles, representing two totally opposing clinical conditions. Two approaches can be followed, depending on the type of adhesive system used: a dry bonding technique, which involves air drying of enamel and dentin and applying a water-based primer capable of re-expanding the collapsed collagen network. B. Wet bonding technique, which leaves dentin a little moist to prevent collapse of the collagen and use a solvent-containing primer to chase water from both dentin and enamel. Wet bonding technique is more consistent and reliable. 63. Collapse of etched dentin.